So once again, welcome to the class on development and congenital malformations of the hologenity. We started this and we did the first part of the lecture because I told you this is likely to be long, so we chose to split it into two. In the first section, we looked at general concepts regarding embryonic origins of the digestive system, and we also looked at formation and derivatives of the primordial gut tube. And remember, it comes from the incorporated part of the yolk sac. So this second part of the lecture on development of digestive system of the hologenity will focus on development and malformations on specific organs. We're going to look at esophagus, stomach, and the intestines. You've noticed that we've not looked at the oral cavity and the pharynx because those ones are covered under head and neck development under pharyngeal arches. So that's why we don't focus on those ones. So we'll just focus on esophagus, stomach, and the intestines. If you remember well, we've done quite a big chunk on anatomy of the digestive system. So we are now on that fourth one, and we've already done the first section. So we're now doing the second section. One more lecture remaining though, that will be focusing on development and congenital malformations of the hepatobiliary system. Before we start, it will be important that you understand some general concepts that you need to know when you are describing development of an organ in general. Today, we are going to focus on esophagus, stomach, and intestines, but another day you'll be focusing on another organ. So some general concept that you need to know when you want to describe the development of a specific organ. There's some things that need to come out. One of the things that need to come out is the embryonic origin. Where does that organ embryologically come from? And when you ask the embryonic origin of an organ, it is important to highlight two things. One, the embryonic site of origin. Where in the embryo or from which structure in the embryo does that organ come from? And then we also want to know the embryonic tissues of origin. And in describing or stating the embryonic tissues of origin, we just want to know the germ layer of origin. Is it ectodermal, endodermal, or mesodermal? And if mesodermal, then which mesoderm? Is it paraxial mesoderm, intermediate mesoderm, or lateral plate, which has two parts again, splanchnic and the somatic layer? If it's ectoderm, is it surface ectoderm, or is it neuroectoderm? So basically, the embryonic tissue of origin is important. The other thing that then we talk about after you've stated the embryonic origin of a particular organ, we want to know the sequence of development. When that organ begins from that embryonic site, on those tissues that you're mentioning, what is the order of events that take place that eventually lead to that organ being in where it's supposed to be in the adult type or postnatally, and it acquiring that morphology that it has? Now, you have to think through that, not in a difficult way, but just in a logical way. If an organ begins to develop in the neck, let's say, but we know that that organ eventually is in the thorax, then there must be some form of migration, for example. And so that word migration or moving or whatever from one place to another need to come out. I want you to be thinking in your mind the final site where that organ is usually found, compare that with where it started from. That will help you understand if there's some motion taking place. Again, I want you to compare the shape of that organ, the final one, and the shape when you're starting. Then see how do we get there. If it has two lobes or three parts, then that means that that segmentation needs to come out. And there's some point that that actually has to happen. So basically, developmental sequence is an important thing that helps you to understand really if you know the order of events that occur when an organ a specific organ is developing. Now you can't put a template, a general template for every organ. Each organ will have its own developmental process. And so today we'll be looking at developmental processes of the esophagus, stomach, and the intestines. For example, now that you know that the intestines are very long, it means that there must be some form of rapid growth that increases length, for example. You know that the stomach is swollen and lesser curvature to the right and greater curvature to the left. It means that there must be some form of rotation for it to achieve that particular position. So that's what I have in mind that I want you also to capture. Lastly, the other thing that it's important to highlight is the congenital malformations that involve that particular organ. Usually there are many congenital anomalies that you can state for any particular organ, but as a concept, maybe it's wise to either highlight those congenital anomalies that are common, they are commonly seen, they're commonly mentioned in textbooks, you know, or they're unique. They may not be that common, but when you see one, your jaws lower down because of how unique they are. You are amazed at how it looks like. So those ones are also important to highlight, or the ones which are of clinical importance. Maybe it's not that unique, maybe it's not that common, but when it's there, it may mean high mortality or something. Perhaps, again, it's important to mention those ones. So that's just to guide you on what the choice of malformation that you need to list for any organ. You may not exhaust all the anomalies that an organ may have, but it is important to just know the common, unique, and the clinically important ones. Now, when you describe congenital anomalies, it is good practice to mention the anomaly and also explain the embryological basis that lead to that particular malformation. For example, if an organ is not where it's supposed to be, then we know that there's failure of migration process. So that we know that, yes, it's ectopic because it did not migrate to its normal anatomical site. So understand those general concepts when you're talking about development of any organ, not limited to intestines, stomach, or esophagus. Any organ, at least know the origin, developmental process, and congenital anomalies. Now, if we bring that home to what is the subject matter today, where we are going to talk about the development of esophagus, stomach, and intestines. So we start with the origin of the hologenity. Where does the hologenity come from? We've mentioned this in the previous class, that the hologenity is derived from the incorporated part of the yolk sac. That's what we call the primordial gut tube. So basically the lumen of the primordial gut tube was originally the lumen of the yolk sac. And we can see that here. This is the yolk sac with the foregut, midgut, and hindgut. And that is the yolk sac remaining outside. This is the vitelline duct. So this is what we're going to form the alimentary canal that answers the site of origin of the hologenity. How about the tissues of origin? We mentioned in the previous class that the hologenity is lined by endoderm inside and splanchnic mesoderm outside. And we see that through all the three images, and the final one capturing very well endoderm inside, splanchnic mesoderm outside. This is the gut tube. So the wall, the tissues of the GIT wall come from endoderm, the inner one, which form the epithelial lining as well as the glands. And these glands are either the intrinsic glands like gastric glands, esophageal glands, glands of Brunner, as well as the extrinsic glands like the pancreas and the hepatic cords and the like. It also comes from splanchnic mesoderm, that germ layer that's external there. And basically splanchnic mesoderm gives rise to the connective tissue elements like lamina propria and the submucosa, even the adventitia. Splanchnic mesoderm also gives rise to the smooth musculature, either the muscularis mucosae or the muscularis propria. The visceral peritoneum, as well as the mesentery, also come from the splanchnic mesoderm. In this image, you can see the mesentery there arising from the splanchnic mesoderm. Neurocrest cells are not left behind. The neurocrest cells form the enteric nervous system. Remember, the neurocrest cells migrate into the developing primordial gut in a craniocaudal sequence, and so giving rise to the ganglionic cells within the wall of the GIT, which give rise to basically the myenteric nerve plexus and the submucosal nerve plexus. Those are the components of the enteric nervous system. Now, don't forget that surface ectoderm also has a role. Why do we say so? We noted from the previous class that there's a place called the stomodium, the future mouth, separated from the gut tube by the buccopharyngeal membrane. This is a place called the proctodium, the future distal anal canal, separated from the cloaca by the cloacal membrane. So both the stomodium and the proctodium are lined by surface ectoderm because it's from outside. And so the epithelial lining of the oral cavity and the distal anal canal is therefore expected to arise from surface ectoderm as opposed to the endoderm. These are the embryonic origins of the hologenity. So with that in mind, our objective will be to explain the development and congenital anomalies of the esophagus. We'll then look at that of the stomach. We'll follow that with the ones of the intestines, both small and large, we'll combine them. Then we look at cloaca and how it's partitioned and its derivatives. We then look at anomalies of the small and the large intestines. And we will finish with congenital anomalies that involve the anterior abdominal wall. I'll try to be a bit quick so that we capture it in good time. I hope you will be following keenly so that I don't lose you. Let's start with development and congenital malformations of the esophagus. So as I've already given you the template in terms of site of origin, the tissues of origin we've already answered, and that applies for all of them. So I will not be repeating the tissues of origin because it's standard. Endoderm, splanchnic mesoderm, neurocrest. At least the segment you're talking about is not within the stomodium or proctodium, so surface ectoderm does not apply. How about the site of origin? We mentioned from the previous class that the primordial gut has three segments: the foregut, the midgut, and the hindgut. The esophagus arises from the foregut segment of the primordial gut. So that is the site of origin. How about the developmental sequence? First, remember that the foregut gives rise to both the lower respiratory system as well as parts of the digestive system. So as part of developmental sequence, what we expect to happen first is the formation of the tracheobronchial diverticulum, which is going to give us the respiratory system. So that structure, which we are calling the respiratory diverticulum, that one, must form first in the ventral aspect of the embryonic foregut. And that structure is the one that is going to give rise to the lower respiratory tree. So once the respiratory diverticulum has formed, what will be next? We'll expect the respiratory diverticulum, which is this one, and the foregut to be separated. The separation of the two is what we call foregut septation. And that's our next step. There must be foregut septation. So the foregut undergoes septation. by formation of some ridges. Those ridges are called tracheoesophageal ridges. We have this ridge there and that ridge, tracheoesophageal ridges. From this image, if this is the diverticulum and this is the Fogart, if you take a cross section there, this is what you see. The tracheoesophageal ridges form and grow towards each other and fuse to form tracheoesophageal septum. This tracheoesophageal septum will separate what is in front, the trachea, which is representing the respiratory system, and what is behind, the esophagus, which represents the digestive tract. So we have formation of the tracheoesophageal ridges, which fuse to form tracheoesophageal septum, separating the trachea in front from the esophagus behind. Remember, what is in front is both the trachea and the larynx, and so we can just call the laryngotracheal tube. After septation, which is an important step, what is next? The next step is increase in length of the esophagus. Now, there are many mechanisms that cause the esophagus to increase in its length, maybe beyond the scope of this particular lecture, but some of them will include even just folding of the embryo in the craniocaudal axis, things like the descent of the diaphragm together with the heart will make the esophagus to increase in length. Multiple mechanisms have been explained, but let's not go through those mechanisms. The step I want you to capture is that the esophagus increases in length. So here, if this is the future esophagus, you can see at this point, the stomach is much high. So this esophagus will increase in length so that the stomach will be much lower down. There is elongation of the esophagus. One important thing that happens to most parts of the hollow organs, and the digestive system is not an exception, is the fact that because usually for these hollow organs, the endoderm is inside and the mesoderm is outside, and that endoderm usually grows very fast. Because of rapid growth of endoderm, the lumen is usually obliterated, and we call that the solid stage of development. Look at these images here. Endoderm yellow is inside and mesoderm, the other color, is outside or in the middle in this case. This endoderm grows faster than mesoderm. So that means that these lumen become obliterated, both in the respiratory tree as well as in the digestive tree. Anything with endoderm inside, mesoderm outside is likely to undergo a solid stage of development. The future alimentary canal must have a lumen. So what happens? There must be another step. That other step is a step of canalization that must occur. Look at this image. So if this is endoderm and that is mesoderm, endoderm grows fast, and so the lumen become obliterated because of rapid proliferation of the endoderm. But the lumen that the GIT that we know need to have a lumen. And this is not limited to the esophagus, even the rest of the intestines must do this. There must be a step of recanalizing. And this recanalization formed through formation of some vacuoles which join to form a lumen. As we can see in the last image there, there's a lumen. So remember the important steps of development of the esophagus. We have formation of the respiratory diverticulum, then Fogart septation, then elongation of the esophagus, then recanalization because there was a solid stage. Good, so that's the developmental sequence. Now we can talk about some congenital anomalies involving the esophagus. The first one is what we call esophageal atresia. It may be alone, or it may be with tracheoesophageal fistula. However, tracheoesophageal fistula can also be alone without esophageal atresia. So the terminologies here are very important. We call it esophageal atresia if we don't have continuous tubular lumen of the esophagus. In simple terms, there's some blockage. So that if you are to put something on the oral cavity, that thing cannot reach the stomach because there is no continuity of the tubular lumen. That is called esophageal atresia. You may have that anomaly on its own, but it may also be present with abnormal communication between the trachea and the esophagus. That communication is a tract which is lined by epithelium, and that's what we call a fistula. So in this case, the fistula is between esophagus and the trachea, so we call it tracheoesophageal fistula. Again, tracheoesophageal fistula can be on its own without esophageal atresia. And that is why then I'm giving it that complicated title there, which is accurately covering or capturing the message I want to pass through. However, in clinical practice, we usually just call them tracheoesophageal fistula with different types. So the problem with this malformation is because of, we think it's because of abnormal Fogart septation process. If the separation of the Fogart into trachea and esophagus does not occur appropriately, then we can get this particular anomaly. There are different varieties of tracheoesophageal fistula, and these different varieties will give us different clinical presentations. Sometimes tracheoesophageal fistula can be on its own, but sometimes can be part of a major syndrome. You can have an association of malformations. And the best association of malformations that has been described is the one we're calling the Vascular association of malformations. The Vascular association of malformation is an association of malformation that involves the following. V stands for vertebral anomalies. So either there's a hemivertebra or a missing vertebra that will give you scoliosis. A stands for anorectal malformations. So either there's anal atresia or rectal, vaginal fistula, urorectal fistula, and the like, imperforatenous. C stands for cardiac malformations. Maybe there's some septal defects in the heart. T and E are the ones we are talking about, trachea and esophagus. So those tracheoesophageal fistula malformations can be there. R stands for renal malformations. So some things to do with the urinary system, and L for limb malformations. You may have a child with all those anomalies, and that constitute the Vascular association of malformation. So TOF can be on its own, or it could be part of the Vascular association of malformations. The images here show you different varieties of tracheoesophageal fistula, and I want to capture them. There are 5 types of TOF. Type A, as we can see, is esophageal atresia because there's lack of tubular lumen continuity of the esophagus, but we don't have a fistula. So we call it isolated esophageal atresia, or you can call it esophageal atresia without tracheoesophageal fistula. That is type A. This child will present with either inability to breastfeed, and if they do so, there's a lot of content that remains in the mouth. Nothing is going down, so the milk just remains in the mouth. Even if they're not feeding, remember, there's usually saliva formation. This baby is not able to swallow saliva, so they usually have a lot of secretions again in the mouth. They have a lot of oral secretions. And importantly, when a baby is born and they're not able to feed, one of the things you'll be doing as a clinician is to try to put what you call nasogastric tube. You insert a tube through the nose pharynx, esophagus, all the way to the stomach, so that you can introduce food, maybe breast milk that has been expressed. For this particular child, again, that cannot happen. The tube cannot go down. So there'll be an ability to insert the nasogastric tube. That's how you'll make a diagnosis of type A. Or basically, you'll make a diagnosis of esophageal atresia. It could be type A or any other anomaly that has esophageal atresia. Type B is esophageal atresia, yes, in the understanding that food cannot go to the stomach from the mouth because there's a lack of tubular lumen continuity. But in addition to that, we have a fistula involving the proximal segment of the esophagus and the trachea. So this is esophageal atresia with proximal tracheoesophageal fistula. In addition to the clinical presentation I've mentioned to you in type A, type B will also present with some level of choking when this baby tries to breastfeed. Type C is the most common type of TOF. There is esophageal atresia, and there is a fistula connecting the trachea and the distal segment of the esophagus. So this is esophageal atresia with the distal tracheoesophageal fistula. This is the commonest type of TOF. Now, this child will present with the clinical picture I've given you up for type A, but in addition, remember, air will be going to the stomach. So when you do a radiograph of the abdomen on this child, we'll see gas in the abdomen, but when you do chest or abdominal radiograph for this child, will not see gas in the abdomen. And that becomes a very important distinction between this and that. This one will have a gasless abdomen. This one, the abdomen will be full of gas. Type D, as you can see, is esophageal atresia with proximal and distal fistula. And type E is tracheoesophageal fistula without esophageal atresia. This one will be picked a bit late compared to the other 4 types of TOF. Okay, that's TOF malformations. The other entity of malformation that affect the esophagus is what we generally call the Fogart duplication cysts. Now, this is an umbrella term. It refers to congenital cystic masses that arise from aberrant budding of the Fogart or its immediate derivatives, which means that esophagus or tracheobronchial or the laryngotracheal tube. So some abnormal budding of the Fogart or its immediate derivatives. Now, the trick here is that when you have that abnormal budding, that abnormal structure becomes separated or amputated from the main structure. So it forms a cyst on its own, but that cyst is next to the derivatives of the Fogart. We call these ones Fogart duplication cysts. There are 3 types of Fogart duplication cysts. Bronchogenic cysts will be the ones that bud off from the tracheobronchial tree, and they're usually lined by respiratory mucosa and filled with mucus. So that cyst has mucus. They're usually mainly in the mediastinum and in the lungs. Esophageal duplication cyst, which is the subject matter of this one. Now, this one's bud from the posterior Fogart. Remember, posterior Fogart is the one that gives you the esophagus. And these ones will tend to be lined with the mucosa similar to that one of the stomach. And that is what makes them even be symptomatic. Because remember, gastric mucosa usually has acid. So if that cyst is releasing some acid, you can actually have perforation at some point. If they get infected, again, they can be symptomatic. And if they perforate, definitely they can bleed. So esophageal duplication cyst may have those characteristics. The other type of Fogart duplication cyst is neuroenteric cysts. This is believed to arise from a different concept, not necessarily abnormal budding of the Fogart, but perhaps due to incomplete resorption of the embryonic neuroenteric canal. The neuroenteric canal is a channel that connects the amniotic sac on one end or ectoderm on one end and yolk sac on the other end, or basically endoderm. And that is usually through where the notochord is going to form. So that canal usually should disappear. If it persists, then you can have what you call neuroenteric cysts. This cyst could be within the vertebral column or within the cranium itself. And when it is within the vertebral column, it is associated with vertebral malformations. If it is within the cranium, it may have some other malformations of the central nervous system. So the images shown here are images of Fogart duplication cysts. The first one, you can see a cyst there, a large cyst next to the trachea. That's most likely bronchogenic cysts. Another one here, we're seeing cyst here next to the, okay, there are two cysts there. And this is basically where you expect the esophagus, because this is the aorta. And so this is esophageal duplication cysts. Here you see a cyst there. This is MRI, T2 weighted sagittal of the C-spine. We see a cyst there filled with fluid because this is T2, so fluid is bright. And we see that compressing the spinal cord posteriorly and also the vertebral column anteriorly. This is neuroenteric cyst. So those are Fogart duplication cysts. Another anomaly of the esophagus is esophageal achalasia. Achalasia of the esophagus refers to that state where the lower esophageal sphincter fails to relax. So the sphincter is tight, does not relax. What's the outcome of that? If the sphincter fails to relax, it means that it's causing obstruction. So as this person eats or swallows things, this part of the esophagus will continue to dilate. What causes this? It is believed that it's caused by absence or degeneration of the myenteric nerve plexus of the lower esophagus. So if you don't have the nerve plexus at that segment, then they cannot coordinate the relaxation of the esophagus. And that is why the esophagus, the sphincter remains tight, closed. It doesn't relax. So this person presented the difficulty in feeding or swallowing. That's what we call dysphagia. And because the baby will not be able to be feeding appropriately, or with the time, there'll be weight loss. When we image this one, what we note is dilatation of the proximal esophagus. We can do that through this study that we usually call barium swallow. A contrast is given to the person to swallow, then we take images. And we can see here, esophagus is dilated proximally, but distally it's tapering as it enters towards the stomach. So that distal tapering and proximal dilatation is very important in diagnosing this. If this is done real time, we're also able to see that the lower esophageal sphincter is not relaxing. If you're taking that real-time dynamic images during what we call fluoroscopy, we'll see that the lower esophageal sphincter failed to relax. All right, that is achalasia. Another malformation of the esophagus are the vascular rings and slings of the esophagus. Now, what are these? Vascular rings and slings of the esophagus refer to congenital vascular encirclement of the esophagus. So there are vessels that go around the esophagus. Now, usually they may go around the esophagus alone or with the trachea. And these vessels are abnormal, they are aberrant, they are not where they're supposed to be. So when you have those abnormal encirclement, we call those ones vascular rings and slings. Maybe call it a ring when it's complete on all round, and a sling when it's only indenting and pulling on one side like a hook. The ones which are complete rings would be mostly symptomatic. The ones which are not complete will be asymptomatic, mainly. The symptoms will be either difficult in swallowing, related to esophagus, or some form of difficulty in breathing related to compression of the trachea. What are these vascular rings? Examples, there are these four. We may have a double aortic arch, which means that there are two aortic arches. Usually, there's only one aortic arch, and it's usually on the left. So when you have a double aortic arch, it means that you have two right and left aortic arches. Or there's another one called pulmonary artery sling. I'm going to show you that one. You may have aberrant right subclavian artery. So this is where the right subclavian artery is not arising from the brachiocephalic trunk as it's supposed to be, but coming from the aortic arch after the left subclavian artery. So it's taking a longer route. And the last one is right aortic arch with the abnormal origin of the subclavian and ligamentum arteriosus. Let's see that one in these images. Maybe that will be better. The first image show you, this is the aorta. This is the main pulmonary trunk. So this is the aortic arch. Remember, this is supposed to be the one that's normal, the left arch. But in this case, we also have a right arch. So the right and the left arch go around the trachea and the esophagus. So that's double aortic arch, encircling the trachea and the esophagus. In this second one, this is the main pulmonary artery. Usually it should come like this. Then at this point, divide into two, the right pulmonary artery and the left pulmonary artery that should come from somewhere here. Like here, you see the left and the right. Now, in this situation, that's not happening. The left pulmonary artery is not arising at this point. Instead, it's arising from the posterior aspect of the right pulmonary artery. And so turns like that and form a sling around the trachea. That is what we call the pulmonary artery sling. So that's the second one. It can indent both the trachea and the esophagus. The third one shows you abnormal origin of the right subclavian artery, which is this artery here. The usual pattern is that you have brachiocephalic trunk, which divides into right subclavian and right common carotid. And then right common carotid gives you external carotid and internal carotid. But in this case, the right common carotid is a direct branch of the aortic arch. The right subclavian artery does not come from the main brachiocephalic trunk. In this case, the right subclavian artery is coming from the distal segment of the aortic arch. So when it arises from there, it takes an abnormal posterior route that will go around the trachea and the esophagus. So this is aberrant right subclavian artery. The last one there shows you a right aortic arch instead of a left aortic arch. We expect the aortic arch to be on the left of the trachea and the esophagus, but this one, the arch is on the right. Remember, it's not double because there's no left one, so you only have the right one. So this is right aortic arch. When there's a right aortic arch, it would have been better to have the left subclavian artery and the ligamentum arteriosum arising from this other side. But in this case, if you have a right aortic arch and those arteries are rising from the left, like here, see the ligamentum arteriosum. Ligamentum arteriosum is the remnant of the ductus arteriosus. And ductus arteriosus is the embryonic shunt that connect the main pulmonary trunk to the aorta to shunt deoxygenated blood away from the lungs. So postnatal, it becomes a ligament. If this ligament is on the left of those two structures, and also if the left subclavian artery, okay, this one arises from this side, so it's on the left, then that will give trouble because again, it will go around the trachea and the esophagus. So that become again a ring. Good, so that's what we've called the right aortic arc with left, in this case, left ligamentum arteriosum. The subclavian artery is not very committal there on being arising from the left, but at least we can see that the ligamentum arteriosum rising from the left, and so it's encircling the trachea and the esophagus. These are the vascular rings and slings. Good. Now we are done with the esophagus. We can now talk about the embryonic development and congenital anomalies of the stomach. In terms of site of origin, the stomach arises from the distal part of the embryonic Fogart. So if this is the Fogart, it arises from the distal part of the embryonic Fogart. In terms of developmental sequence, the steps are these. First, the future stomach, or the site that's supposed to form the future stomach, form a dilatation. A very uniform dilatation. We usually describe it as fusiform dilatation. But the concept here is that there's a swelling. And I want to capture that swelling. Perhaps that's the swelling. In the site of the future stomach, there's a swelling. After that swelling, what is next? In this swelling, the anterior part, the anterior wall of the swelling usually grows slower than the posterior wall of that swelling, so that the posterior border of the future stomach grows faster than the anterior border of the future stomach. Ask yourself the implication of that one. If you have the anterior border being slower than the posterior border, it will mean that this future stomach is going to form a curvature. So that leads to formation of the curvatures of the stomach. Remember, the stomach has curvatures. And I told you, think about the final morphology and ask yourself, how do you get there? So this is how we explain the curvatures of the stomach. The anterior border that grows slowly becomes the lesser curvature, as you'd expect. So that becomes a lesser curvature. And the posterior border that grows faster, this one, becomes the greater curvature. That explains why there is curvatures of the stomach. Lesser and greater curvature. We also see that one in this one. That's a lesser curvature, there's a greater curvature. After that concept that I'm calling differential growth, the stomach undergoes rotation. So rotation is also an important step of stomach development. How does the stomach rotate? Stomach rotates embryologically in two axes. There's a vertical axis of rotation and the anteroposterior axis of rotation. Let's talk about rotation in the vertical axis. And let's focus on the first two images up there. So look at this image here. It's showing you the fusiform dilatation, very uniform dilatation. That's what we call fusiform dilatation. And we've alluded to the fact that the anterior wall grows slowly and posterior wall grows faster. Now they're superimposed. If you're looking at this, let's say it's an AP view, this one. So we are not able to see the curvatures. This is the axis of rotation of the stomach, the vertical axis. The stomach rotates about 90 degrees in the clockwise direction. So here we are making an assumption that you're looking at it from the top, from the sky, from the head of the patient or the individual. And so clockwise would mean that direction. The implication of that is this, that the lesser curvature is going to go to the right and the greater curvature is going to move to the left. And that is what's being captured here. So lesser curvature goes to the right and greater curvature goes to the left. And we know that that is how the stomach is. The greater curvature is to the left and the lesser curvature is to the right. If you think through the fact that the greater curvature goes to the left and the lesser curvature goes to the right, then you should also think through the positional changes of the surfaces If you have an anterior and a posterior border, then it means that embryologically you have the right and the left surface. The left surface becomes the anterior wall of the stomach, and the right surface becomes the posterior wall of the stomach, or the posterior surface of the stomach. Again, think about the vagus nerves that run on either side of the esophagus and then the stomach. The left vagus nerve becomes the anterior vagal trunk. The right vagus nerve becomes the posterior vagal trunk. We can also think about the omentum. The omentum refers to the mesentery that suspends the stomach. So initially, we have the ventral mesentery of the stomach. We call it ventral mesogastrium. And the dorsal mesentery of the stomach, we call it dorsal mesogastrium. The dorsal mesogastrium goes to the left and becomes what we call the greater omentum of the stomach. And the ventral mesogastrium goes to the right and becomes what we call the lesser omentum of the stomach. The image here shows you the stomach with the dorsal mesogastrium and the ventral mesogastrium. So this ventral mesogastrium will become the lesser omentum, and this dorsal mesogastrium will become the greater omentum of the stomach. At this level, you can see that the stomach is the only one with ventral mesentery. Otherwise, the rest of the intestine only have a dorsal mesentery. They don't have a ventral mesentery. The image here shows a cross-section through the embryonic abdomen with the mesentery in place. So this is the future stomach. And so this is the dorsal mesogastrium. And this is the ventral mesogastrium. Within the ventral mesogastrium, that's where the liver will form. And within the dorsal mesogastrium, that's where the spleen will form. We are looking at this from the foot of the individual now. And so what was initially clockwise, when you look at it from the sky, will now be rotating this manner if you're looking at it from the feet of the individual. This will be the right side of the patient, and this will be the left side of the patient. The ventral mesogastrium, as we can see, goes to the right, together the liver, and that's why the liver is on the right. The dorsal mesogastrium, together the spleen, goes to the left. And that is why we have the spleen again on the left. Now, capture that here. This space here, the right peritoneal cavity, and this space here, the left peritoneal cavity, will become some important spaces in the abdomen. After that complete rotation of the stomach in the vertical axis, because after it has rotated, the liver will move somewhere here, which we see there, and the spleen moves to somewhere here, which you see here. So what has become of the right and the left peritoneal surface spaces, the right peritoneal space, which is this one here, become hidden behind the stomach. It forms what we call the lesser sac. The lesser sac is also known as the omental bursa. Then this space here, the left peritoneal space or cavity, is this one here. This is what we call the greater sac. If you are to operate on someone's abdomen, when you cut through the anterior abdominal wall, you enter the greater sac first. See the omentum. So this is the dorsal mesogastrium, which becomes the greater omentum. This is the greater omentum. And this is the ventral mesogastrium, which becomes the lesser omentum. That was rotation in the vertical axis. Now let's see rotation in the anteroposterior axis. So this is the anteroposterior axis. Again, the stomach rotates about 60 to 70 degrees in the clockwise direction. If you look at it from the front, and assume that the stomach you're looking at here is the stomach of the individual in front of you. Because of that 60 to 70 degrees rotation, the fundus of the stomach goes down and to the left, and that goes to get the greater curvature. While the pylorus of the stomach, which is this one, and that goes up and to the right to get the lesser curvature of the stomach. And that is why now the future stomach takes that position. The fundus is down and to the left, the pylorus is up and to the right in that way. Well, the fundus is still at a higher level than the pylorus because this rotation is not beyond 90 degrees, it's about 60 to 70 degrees. What about the positional changes of the omentum? The lesser omentum, which was here, now, which was anterior, remember, it is now on the right side, just above the lesser curvature. The great omentum that was behind here is now down and on the left side. Okay, so that has captured on the upper end, the rotation in the vertical axis, leading to lesser curvature going to the right and greater curvature to the left, as you can see there. And the images below show you rotation in the anteroposterior axis. The fundus goes down and to the left, pylorus goes up and to the right. That is how the stomach rotates. If you want to remember easily the development of the stomach, you can use your left hand on top of your epigastrium. Now it has to be left hand, and it has to be on the epigastrium with the palm on the epigastrium. If you can see my video that way. So I want to describe the sequence of rotation of the stomach. So have that in mind. So first, remember that the stomach arises from the distal Fogart as a fusiform dilatation. The tissues of origin we've already underscored when we were talking about the common concept about development of the JT. That we have endoderm giving you epithelium, splanchnic mesoderm giving you connective tissue, smooth muscle, and then and mesentery, and neurocrest gives you the enteric nerve plexus. In terms of sequence, there's differential growth. So the lesser curvature, the anterior border, which is the side of the thumb, grows basically slower than the posterior border, which is now the side of the small finger. So if you put that this way, look at my video, with the thumb, if you use your left hand, then I want you to make your thumb be the one in front and the small finger to be behind. So the side of the thumb is a lesser curvature, and the side of the small finger is a greater curvature. That sounds ambiguous, but we'll put it that way for the sake of us understanding the rotation. Now, this is where that illustration applies. The rotation in the vertical axis is 90 degrees, which makes the greater curvature goes to the left and lesser curvature goes to the right. So rotate your palm in such a way that's possible, and only this way is possible. Lesser curvature, small finger goes to your left, greater curvature, the thumb goes to your right. If you use your left hand and you put in the manner that I described to you, only that rotation is possible. So we use this so that we can remember the direction, the rotation of the stomach, so that don't confuse. Then while you're there, rotation in the anteroposterior axis will make it happen this way. Again, if you used your left hand, only that rotation is possible, where the side of my wrist is the fundus, goes down and to the left, and the side of the fingertips is the pylorus, goes up and to the right. That's a summary of how the stomach develops. Let's talk about congenital anomalies of the stomach. The commonest that I want to talk about is hypertrophic pyloric stenosis. In this anomaly, we have abnormal thickening of the pyloric muscle. And because of this abnormal thickening of the pyloric muscle, we have gastric outflow obstruction, to mean that gastric contents cannot leave easily from the stomach to the duodenum. Gastric emptying is blocked. Gastric outflow obstruction or gastric outlet obstruction. We don't quite consider this congenital because children born usually don't have this anomaly clinically at the time of birth. But we see this happening in children between 2 to 12 weeks of age. Maybe the optimal is around 6 to 8 weeks. In these particular children, the pyloric muscle becomes thickened. And so there's difficulty of milk to move from the stomach to the duodenum. So they present with recurrent vomiting. This vomiting usually does not contain bile. Why? Because remember, bile enters at the duodenum, but this obstruction is at the level of the pylorus. So whatever they're vomiting does not have bile. It's non-bilious vomit. We make a diagnosis based on ultrasound image, and the image you're seeing here, that darker one, is an ultrasound image of the pyloric region. This is the liver. We usually measure the thickness of the pyloric muscle. That's what's being measured there. We also measure the length of the pyloric canal. That's what's being measured there. We can also measure other measurements like the whole diameter of the pyloric region to make a diagnosis. Another anomaly we can see here is that there is lack of tubular lumen continuity from the stomach to the duodenum at the level of the pylorus. So the term given is atresia. Congenital pyloric atresia means that the pyloric canal is blocked completely. So there's obstruction, and hence food cannot move from the stomach to the duodenum. It can be involving the pyloric region as well as the antrum, the pyloric sphincter as well as the antrum itself. So generally we just call it pyloric atresia, but yes, it affects all that region. This particular baby will not be able to feed at all, and if they feed, they'll be vomiting everything. We can make a diagnosis based on what we call barium meal study. Not barium, basically, we use another contrast, not barium, but basically we still call it upper J study. So we put a contrast for the baby to swallow, and that contrast goes through the esophagus to the stomach, but now it can't move from the stomach. So what do you see? Dilatation of the stomach and lack of movement. And look at the rest of the abdomen. It is non-gaseous, which means that there's no gas moving. Remember, gas comes from here to move to the intestine. So if there is complete obstruction, this abdomen becomes gasless, apart from just the gas of the stomach, maybe, if there was no this contrast material. This one has various associations, which means that rarely will it be happening on its own. When you see a baby with gastric or pyloric atresia, they may also have other malformations, and so we usually have to screen for those other malformations. Another anomaly of the stomach is antral mucosal diaphragm and antral mucosal webs. So antral from the word antrum, mucosal from the word mucosa. The mucosa at the level of the gastric antrum has either a diaphragm or a web. So a diaphragm will be almost complete like that with a small opening. A web will be something eccentric, not necessarily almost completely like this one, but eccentric. That's a web. So they usually hymen-like ring of mucosa, together muscularis mucosa and some mucosa within the gastric antrum. We see it based on upper J studies where we can see this slight narrowing. You can see an opening. So it's not complete obstruction, but there is a membrane. So that could be most likely a diaphragm from how it looks. This one causes partial obstruction within the stomach. And so basically the baby might be vomiting frequently, and that means that they don't really grow properly. And if this baby swallows some foreign body, that foreign body is unlikely to pass through that particular narrow opening. So it will cause retention of foreign body within the stomach. This other anomaly of the stomach is what we call congenital microgastria. Congenital microgastria simply means that the stomach is congenitally small. Usually when it's small, it's also tubular. And that means that it may not be able to store food appropriately. So to compensate, this esophagus usually tend to distend to be compensating or working as an accessory stomach. And this is usually because of a lot of reflux from the stomach now to the esophagus. As you can see in this upper GI studies, we have esophagus distending and the stomach is appearing tubular, almost the same size as that of the esophagus. So that is congenital microgastria. This one also has multiple associations to mean that you may have other anomalies related to it. Okay, now we can talk about development of the intestines. We'll focus both on small as well as large intestines. First, let's agree on embryonic origins of the intestines for you to remember. Remember, we're talking about development of the hologenity. And so, in terms of site of origin, intestines still come from the primordial gut tube. They come from all the segments. The intestines come from all the segments of the primordial gut tube: foregut, midgut, and hindgut. However, the midgut and the hindgut are the ones that contribute predominantly to the intestines. Only the small distal segment of the foregut gives you a small part of the intestine. Remember, the distal foregut gives you part of the duodenum. The proximal segment of the duodenum comes from the distal foregut. Small portion. But the whole of midgut and the whole of hindgut gives you intestines. Small and large, as you're going to see. If you take this to be the foregut, up to somewhere there, perhaps now this is already duodenum. So only that part of the duodenum comes from the foregut. The rest of the duodenum, jejunum, ileum, cecum, appendix, ascending colon, transverse colon from the midgut, transverse colon continuing, descending colon, sigmoid colon from the hindgut, and the rest of the large gut, which means anal canal and rectum, come after partitioning of the cloaca to give you anus and rectum. We've answered the site of origin. The tissues of origin, we'd already alluded to that. We said that the tissues of origin, we have endoderm, which gives you epithelium and glands. Splanchnic mesoderm gives you connective tissue, smooth muscle, visceral peritoneum and mesentery. And neurocrest gives you enteric nervous plexus. That is important to mention because of how close that would be with the malformations we're going to talk about of the intestines. That's why I'm repeating them. Now let's talk about the developmental sequence. I've given you the site of origin and I've given you the tissues of origin for the intestines. What's the developmental sequence? The intestines develop in a very interesting manner. Perhaps one of the spectacular developmental processes that I've learned about embryologically. The first thing we want to talk about, the segment that's supposed to give you intestines grow very fast. And this segment largely affects the midgut. So the midgut grows rapidly. Now think about that. If the midgut segment, this one, grows rapidly, what will that lead to? That segment, midgut, will increase in length. So rapid proliferation causes elongation of the midgut. Midgut is elongating, yet the space here is not really tiny, is not really adequate for it. The ends of the midgut are fixed. So because of that elongation, for it to fit in that small section, it will have to bend. The elongation leads to formation of a bend. The first bend of the intestine is that one. We call the primary intestinal loop, or you can call the midgut loop. So this is the midgut loop. It forms as a result of increased elongation, yet the space is fixed. The ends, or rather, are fixed. So that's the midgut loop. Even that one, that's the midgut loop. The first bend of the intestine. This midgut loop has an apex where we have attachment of the vitelline duct. Remember, when the yolk sac become incorporated, there is the vitelline duct that still connect the midgut to the outside. So this is the vitelline duct. And that vitelline duct is the one that's attaching the apex of the loop. That makes us to have two segments of the loop. There's this segment continuous the stomach, is the cephalic segment, or you call it the cephalic limb of the midgut loop. And there's this segment, which we call the caudal limb of the midgut loop. So the midgut loop has two segments, the cephalic limb of the midgut loop, the caudal limb of the midgut loop. Remember that. The apex of the loop is attached to the vitelline duct, connecting it with the yolk sac that is outside the body. That is rapid proliferation that has led to elongation and formation of the primary intestinal loop. What's the next step? I've already told you that the apex of the loop is attached to the yolk sac via the vitelline duct. This region of the apex corresponds with the region of the ileum. So if that is so, we can make some fundamental statements at this point. That the cephalic limb of the midgut loop represents the small gut. The caudal limb of the midgut loop predominantly represents the large gut. And I said predominantly. I want you to note the following as well. That the loop of the midgut, this one, forms around this vascular pedicle, the pedicle of the superior mesenteric artery. Remember from our previous section, we mentioned that the superior mesenteric artery is the artery of the midgut. So the cephalic limb represents the small intestines, while the caudal limb predominantly represents the large intestine. And I'm saying predominantly because if this is the ileum, then there's a small part of the caudal limb that is still ileum, as you can see in that area there. That could be the ileum because we can see the cecum is most likely forming from somewhere there. After the loop has formed, what happens? One thing that is very unique, what makes it really fascinating, is that the intestine herniates. It goes through the umbilicus. In simple terms, the intestines leave the abdomen of the fetus. Why does that happen? At this point, the development is rapid for the intestines, yet the fetal abdomen is very small. And in addition to it being very small, there are some organs that also occupy large space. The fetal liver is very big at this point because it's one of the sites of formation of blood. The fetal kidney systems are also occupying a big space at this point. You don't know this yet, but when the kidneys develop, there are 3 embryonic kidney systems. The first ones we call pronephros, form in the neck region. They have already disappeared by this time. The second ones are the ones which are many, prominent, and they're present at this point. We call them the mesonephros. They eventually disappear, but at this point they're there. So they occupy a large space within the fetal abdomen. Think about those 3 factors. Mesonephros are prominent, occupying large space of the fetal abdomen. The liver is prominent, occupying large space of the fetal abdomen. And we are saying fetal abdomen is also very tiny. So with those 3 challenges put to the intestines, we are saying in those many ones that intestines don't have enough space to continue to grow within the fetal abdomen. So it makes that wise decision of leaving the abdomen through the umbilicus to outside. And that is what we call physiological umbilical herniation. So this image shows you the herniation of the midgut loop through the umbilicus. This is what we call physiological umbilical herniation. Physiological umbilical herniation occurs with the guide of the vitelline duct, as you can see there, because the vitelline duct yolk sac is still outside, so it's being guided by the vitelline duct. That physiological umbilical herniation usually occurs at around the 6th week of gestation. The aim of the herniation is so that the intestine can continue to grow outside, increase in length. That happens for close to 1 month when the intestine just outside. When the intestine is herniating, something unique also happened to the intestine. The intestine rotates 90 degrees in the anti-clockwise direction around the axis of the superior mesenteric artery. Now I want you to capture that in a better way. Look at this part. If this is the cranial limb or the cephalic limb representing the small bowel, it is up. And this one is the caudal limb representing the large bowel, is down. So I want you to imagine that on someone facing you directly. We are saying that if you look at that person, their intestine rotates, according to your view, 90 degrees in the anti-clockwise direction. As that herniation process is taking place, the intestine are coming out, they rotate. So with that in mind, I want you to think through what are the effects of that external rotation. You'll notice something. This image captures for you the small bowel up there and the large bowel down there. And this one captures for you how it rotates. So the large bowel goes to the left and small bowel goes to the right, as you can see. To the right of the individual for the small bowel, to the left of the individual for the large bowel. The intestine continue to develop within the hernia sac for about 1 month, during which the vitelline duct begin to involute. The involution of the vitelline duct usually occur between week 9 to week 18. So it will start to involute when the intestine are still within the hernia sac, but it will continue to involute even after the hernia has been reduced. When it reaches some time, the hernia becomes reduced. And hernia reduction, the return of the physiological herniation, occurs from the 10th week. It doesn't occur all of them on the 10th week. Maybe it may begin from the 10th week up to the 12th week there. At least the return of herniation occurs from the 10th week onwards. Usually around the 10th week, 11th week. When the return is occurring, which means that whatever had herniated goes back, the small bowel is the one that leads the way. The small intestine, and in this case, the duodenum is the one that leads the process of going back. So the duodenum goes back first into the abdomen, followed by the rest in that order. You may ask yourself, what is making the intestines to go back? We really don't know, but we think it's just the reversal of the mechanism that led it to herniate. Perhaps the fetal abdomen is now adequate, which is true. That's now bigger, the baby's been growing. Perhaps the kidney systems are now reduced, which is also true. This time round, we have the third kidney system. The second kidney system, mesonephros, have disappeared. We have the third kidney system, which form in the pelvis anyway. We call them metanephros. Perhaps the liver is not that prominent, which could also be true, because at this time now, at least the bone marrow is now trying to also take over the function of formation of blood. The liver is still forming blood though, but at least the pressure not much on the liver now. So there could be multiple reasons that lead to enough space within the fetal abdomen that accommodate the intestines back. All in all, there is hernia reduction. Now, importantly, during the return of the herniation, the intestines rotate another degrees. The degrees of rotation is now 180 degrees in the anti-clockwise direction, and we call that internal rotation. This internal rotation will largely affect the large bowel because the small bowel is the one that started leading the way in returning. So it will not really rotate much. But the large bowel, the one that is still remaining outside, will rotate much. So let's see that from here. The first image shows you the duodenum going back. The second image shows you duodenum going back, but the large bowel is rotating. The third image shows you duodenum that has already gone back and a large bowel that has rotated. So the rotation, remember the first one, the small bowel was up and large bowel down. So for external rotation, large bowel went to the left and small bowel went to the right. Now this rotation is 180 degrees anti-clockwise. The large bowel goes up and to the right, and that's what we see here. So large bowel came from down, went to the left during external rotation, then up to the right. So from here to there is 90 degrees. Then from here to there is 180 degrees. The large bowel rotates a total of 90 plus 180, a total of 270 degrees in the anti-clockwise direction. And that is why the large bowel takes the peripheral position of the abdomen, as we all know, while the small bowel takes the central position of the abdomen, as we all know. The return of the herniation process also explains to you why the duodenum is hidden, because the first one to go back, while the others are exposed. They are later going back, but the duodenum is the first one that leads the way. It also explains to you why the duodenum is behind the superior mesenteric artery, because it goes back first, then now the rest come on top. So these images still capture for you the return as well as the rotational process. If you start from A, herniation with the two loops, cephalic and caudal, then B, external rotation 90 degrees, small bowel to the right, large bowel to the left. C also captures that, external rotation. D is now capturing internal rotation, perhaps and 90 degrees, not yet complete, and then E, complete rotation. But D and E also capture return of the herniation. So we see whatever was in the hernia sac has now gone back to the abdomen. When you have a very rudimentary part of the vitelline duct, I told you vitelline duct will disappear completely by the week 18. After all that misbehavior of leaving the abdomen and going outside, then going back, to ensure that the intestines do not misbehave again by leaving, there must be a process of fixation. So fixation is a process of losing the dorsal mesentery. In the earlier images, I showed you that the intestines have a dorsal mesentery. Some parts of the intestine lose their dorsal mesentery. Now, the parts of the intestine that lose their dorsal mesentery are which ones? We have the duodenum loses its dorsal mesentery. We also have the ascending colon losing its dorsal mesentery. And we have the descending colon losing the dorsal mesentery. Those are the parts of the intestine that lose their dorsal mesentery. By loss of dorsal mesentery, it means that those segments of the intestines become attached to the posterior abdominal wall. They become fixed. Those fixed structures are therefore termed retroperitoneal structures. They don't have a mesentery, so they're just lined by peritoneum on one side. Their posterior walls abut the posterior abdominal wall. They are not free to move. They are not mobile. They are fixed. So fixation is a regression of the dorsal mesentery involving those three segments. The ileum and jejunum, transverse colon, sigmoid colon retain their dorsal mesentery. So they are termed intraperitoneal. And those organs that retain their dorsal mesentery are now intraperitoneal. They're also mobile. They are free to move. You can actually reflect them from one side to another. The ones which don't have a dorsal mesentery are fixed. They can't move. That's the order of development of the intestines. I hope you've captured those order very well. The images here just try to summarize the process of rotation so that you understand. In the first rotation, which is a 90 degrees anti-clockwise external rotation, the cranial limb goes to the right and caudal limb goes to the left in this one. So this caudal limb goes to the left of the individual. The cranial limb goes to the right of the individual. That means that the small bowel has gone to the right and large bowel goes to the left. In the other rotation, internal rotation, the large bowel goes up and to the right. And that is why the transverse colon, the colon basically large bowel takes the peripheral position of the abdomen, and the small bowel takes the central position of the abdomen, as we see in the final image. Let's make a summary of those mouthy things you said about origin and developmental sequence of the intestines before we look at their malformations. In terms of site of origin, the whole of midgut and the whole of hindgut. For the foregut, just a small segment, the distal foregut. In terms of tissues of origin, we've mentioned those three germ layers contributing to some specific things. Endoderm gives you epithelial lining and glands of the intestines. Splanchnic mesoderm gives you smooth muscle, connective tissue elements, mesentery of the intestines. Neurocrest gives you myenteric and submucosal plexus. In terms of developmental sequence, there's rapid proliferation, which leads to increase in length. And because of that increase in length, there's formation of a loop. We call that the primary intestinal loop, which has two limbs, cephalic and caudal limb. Cephalic limb represents the small intestine and the caudal limb represents the large intestine. Then the intestines herniate through the umbilicus. We call that physiological umbilical herniation, during which it rotates 90 degrees in the anti-clockwise direction around the axis of the superior mesenteric artery. That leads to the small bowel going to the right and large bowel going to the left. It will continue to develop within the hernia sac, during which the vitelline duct will begin to involute, not completely, but at least begin to involute. After that, because there's enough space, there will be hernia reduction from around the 10th week of gestation, beginning with the duodenum in that sequence, during which there's also rotation 180 degrees in the anti-clockwise direction, leading to the large bowel going up and to the right. The small bowel is not affected much because it's the one that started to migrate inwards. So it's not affected much in the rotation. To prevent this from happening, there's loss of dorsal mesentery for the duodenum ascending colon and the descending colon. We call that fixation. Now let's talk about the cloaca and its derivatives. First, you need to understand what the cloaca is. Remember, the cloaca is the inferior common union of the hindgut, this one, and the allantois, that one. This inferior common union represents the primitive communication between the urinary system, represented by the allantois, and the digestive system, represented by the hindgut. So we are saying that embryologically, stool and urine meet at some point. In mammals, and we are one, the cloaca becomes separated so that stool and urine go different ways, as we know. The separation of the cloaca into the urogenital system and the digestive system occur through formation of a septum that goes through the plane of the cloaca. And let me show you that in this way. It occurs through formation of a septum of mesenchymal tissue. That septum of mesenchymal tissue is this one. This septum of mesenchymal tissue grows in the coronal plane caudally, splitting the cloaca into two. That septum is called the urorectal septum. So it grows all the way until it reaches the cloacal membrane. Or in this image, this is the urorectal septum. It grows down until it reaches the cloacal membrane, which is that one. When it reaches the cloacal membrane, it splits the cloaca into two. The anterior segment is called the urogenital sinus, and the posterior segment is called the anorectal canal. So the anorectal canal is the one that gives you, as the name suggests, the anus and rectum. The part of the anus that this gives us is the proximal part of the anus, because the distal part of the anus comes from this space here, the proctodium, which is this one here. The proctodium will give you the distal anus. So only the proximal anus comes from the cloaca. The distal anus comes from the proctodium. Urogenital sinus, this one, will give you urinary and reproductive structures. We'll talk about that in a different lecture. So we can just give the derivatives though. Urogenital sinus gives you the following: the urinary bladder, part of the urethra, part of the vaginal canal, and the prostate gland. The anorectal canal gives rise to the rectum and the proximal anal canal. As I mentioned, the distal anal canal comes from the proctodium. And so this image captures for you the concept of dual origin of the anal tube, lower part from the proctodium, upper part from the cloaca. After the septum has formed, there is splitting. And so this region here is the one that will form the anal canal. As you can see, initially there's a membrane, the anal membrane, which is basically part of what was supposed to be the cloacal membrane. This is the cloacal membrane. After the septum has joined the cloacal membrane, you have the urogenital membrane anteriorly and the anal membrane. So this anal membrane must undergo cavitation or canalization, as you can see in this particular image. And this will what will cause the patency of the anal canal after the anal membrane has perforated. All right, so this image capture for you those stages of development of the anal canal, from the concept dual origin, the presence of the cloacal membrane, the cloaca itself, urorectal septum growing towards the cloacal membrane, splitting it into two, urogenital membrane and anal membrane, and the fact that the anal canal here has dual origin. We have the proctodium and this other side from the cloaca, and eventually we have that channel. Great. Let me take you through congenital anomalies of the small and large intestines quickly. One of the anomalies that we see in the intestine is intestinal atresia. The term atresia means lack of tubular lumen continuity, as I mentioned to you earlier. So basically it means occlusion. There are three types of atresia. In type A, the one you're seeing up there, there's a membrane, and this membrane is causing obstruction. This is the most frequent type of atresia, and this can be surgically corrected easily. So usually the membrane is consistent of mucosa and submucosa, but it closes the lumen completely. In the second type, what we call type B, the proximal and the distal ends have blind ends, but they're joined by fibrous material between the two. So there's a fibrous band. And as we can see, there's still mesentery on that fibrous segment. In type C, which is the last one, the two segments are separated from one another and there's no mesentery. All of them are types of atresia. So atresia simply means blocked. You may have duodenal atresia, jejunal atresia, ileal atresia, colonic atresia. Any segments can be atretic. So if you're ever asked to list some anomalies of the intestines, don't say that exam was really hard. You can actually just mention any segment, then you say atresia. Take note that if you have atresia, the proximal segment will be dilated and the distal segment will not be expanded. Take note also that most of the intestinal atresia affect the duodenum. So in as much as we're saying that you can have any atresia, most of the atresia involve the duodenum. So we talk of duodenal atresia. This image captures for you, therefore, duodenal atresia. It means blockade at the level of the duodenum. When you use the term atresia, we mean occlusion. Sometimes the duodenum may not be atretic, but just having a narrow lumen. And that's the term, stenosis, the term we give for narrowing of the lumen. So it's incomplete occlusion. That's called stenosis. So again, you can have stenosis of any part, but yes, duodenal stenosis is one of the things. What causes atresia or stenosis of the duodenum? We think it's due to failure or incomplete canalization of the duodenum during development. From the solid stage of development that I told you, that most organs have a solid stage of development, you need to have recanalization. So usually recanalization of the duodenum occur around the week 8 to 10. If that does not happen completely, then you may have atresia. This is what we see. We can picture it even before birth, during obstetric ultrasound, when we capture this, the fetal abdomen. So this obstetric ultrasound, this is the fetal abdomen. So this is the stomach of the baby, and that's the pyloric region. This is the duodenum. So we see the first part of the duodenum being dilated, but that's the only thing we see. We see a dilated duodenal cup, and there's nothing else. We call this on the double bubble sign. So there's that bubble for the stomach, and there's that bubble for the duodenum. Even radiologically, which means after the baby has been born, if we take a radiograph of the baby, we see two gas bubbles, one for the stomach and one for the duodenal cup, and nothing else, no other gas bubble. That is diagnostic of duodenal atresia, double bubble sign. Usually, if a baby has duodenal atresia, they'll present with vomiting bile. Whatever they're vomiting will be having bile within it. And you understand now the obstruction is distal to the entry of the common bile duct. So when they vomit, they'll be vomiting things which contain bile, as opposed to pyloric stenosis or antral atresia, where the vomiters will not have bile. The other association of this anomaly, many of them, so it may not be on its own. So when you see duodenal atresia, we look for other anomalies. If it is duodenal stenosis, commonly it's caused by annular pancreas. Annular pancreas is pancreas that has gone round the duodenum. We will see what is annular pancreas when you look at development and malformations of the hepatobiliary system. But basically, it's pancreas that goes round the whole of the duodenum. So it's encircling the duodenum congenitally. It will cause narrowing of the duodenum. We can also have vitelline duct malformations. These are due to remnants of the vitelline duct. So if the remnants of the vitelline duct fail to obliterate completely, we may have various portions that persist that give us this malformation. You may have vitelline duct fistula. That is what we see in the first image, where we have the intestines communicating with the umbilicus directly. We may have vitelline duct sinus, which you see in this image here. We see a tract with a blind end through the umbilicus. So you can call that umbilical sinus or vitelline duct sinus. You may have fibrous cord, which is this part here. So basically just a fibrous material connecting the intestines to the anterior abdominal wall. You may have Merkel's diverticulum, which is this one. So these are outpoaching from the ileum. Remember, if it is Merkel's diverticulum, it will be emerging from the ileum. And usually Merkel's diverticulum will also contain some gastric tissue, gastric mucosa. And that is what may cause them to have trouble, basically because they also release acid. This is still fibrous cord. In the last image, so this should be vitelline duct cyst, not sinus, but vitelline duct cyst. These are cysts. A cyst is a cavity with blind end. There's no opening. Importantly, these vitelline duct anomalies are usually lined by columnar epithelium, almost similar to that of the stomach, but they may also have some pancreatic tissue, and they may have some intestinal epithelium as well. This is an image of Merkel's diverticulum. That one, you see it outpoaching from the intestine. That is still Merkel's diverticulum from the intestine. Merkel's diverticulum will involve the ileum because that's where the vitelline duct attaches. So these are still images of vitelline duct anomalies. Diverticulum, fistula, cyst, and fibrous cord. The next one is enteric duplication cysts, which we also call gastrointestinal tract duplication cysts. Now, these are congenital cystic masses that arise from aberrant budding of the primordial gut tube. We've talked about them in a different way when we were looking at the Fogart duplication cysts. It's a similar concept here, except right now I'm focusing primarily on the ones that involve the gastrointestinal tract. Remember, when we talked about the Fogart duplication cysts, I mentioned that those that can affect the esophagus, that those that can affect the trachobronchial tree, and that those ones that involve the neuroenteric canal. Those are Fogart duplication cysts. So now, the ones that are involving the GIT, which esophageal duplication cyst was one of them, is actually an example of this enteric duplication cysts. So the concept here is that there's aberrant budding from the primordial gut tube, then that abdominal structure become amputated and isolated from the main alimentary canal. And so these cysts are usually characterized by some three things. One, they'll be found adjacent to or on the wall of the GIT. And usually the part that they're adjacent to will take the name of the cyst. For example, if it's located next to esophagus, then you call them esophageal duplication cysts. If it's located next to the duodenum, then they're duodenal duplication cysts. If it's located next to the ileum, then you call it ileal duplication cyst. The other characteristic about them is that their wall contains smooth muscles. So they have smooth muscles within the wall. And lastly, that the mucosa within that particular cyst is similar to the mucosa of the GIT. Those are their characteristics. In terms of the order of the structures affected or the different types of duplications, enteric duplication cysts that we have, most of them occur at the level of the ileum, followed by esophagus. Then you have the large bowel, jejunum, stomach, and duodenum in that order. So the most common ones are ileum and esophageal duplication cysts. The mucosa of the cyst is not necessarily similar to the mucosa of the adjacent segment of the GIT. What I mean is this. For example, when you have an esophageal duplication cyst, the mucosa of that cyst is not necessarily similar to the mucosa of the esophagus. That mucosa could be containing mucosa of the stomach, even though it's an esophageal duplication cyst. Or it may be containing mucosa of pancreatic tissue, although it is still an ileal duplication cyst. So that is important to know about the enteric duplication cysts. Now, this cyst may not be of clinical importance unless maybe they're compressing on a particular structure because they're so big, or the mucosa they contain is active for a number of reasons. And the mucosa that are usually active are the ones that contain stomach mucosa, because those ones could be producing acids, and pancreatic tissue because those ones could be producing enzymes which are digestive. And so those ones become clinically important mucosa. Otherwise, if the mucosa is not very active physiologically, then the only challenge will be that the cyst could be causing some compression on adjacent structures. Otherwise, they'll be very benign. So the images you're seeing here on the first one are images of gastrointestinal tract duplication cysts. This one looked like it was adjacent to the small bowel. That's the cyst. This one is the cyst. It's a very big one, adjacent again to the small bowel, as you can see that. And the image there on the last one shows you an MRI image of a cyst that was located at the level of the sacrum and rectum. So that is the sacrum, and that's the cyst. So the cyst here, that one is different from that. This is ovarian cyst, but this one here is a duplication cyst, just behind the rectum and in front of the sacrum. You see, this is uterus, and so this is the rectum, and that's the cyst. So this cyst could be anywhere. The next malformation I want us to talk about is the malrotation of the intestines. We can call it midgut malrotation. Now look at these images. The first one shows you the normal pattern where the small bowel is usually at the center and the large bowel is at the periphery. Remember, during development, the large bowel rotates 270 degrees in the anti-clockwise direction. So if you start from here, the caudal limb of the midgut loop, external rotation took it somewhere there, 90 degrees to the left. Then internal rotation, take it up and to the right, 180 degrees, anti-clockwise. And so the large bowel become peripheral and the small bowel is central. Now, malrotation would be because there's improper completion of the normal rotational process. Because of that improper completion of the normal rotational process, we may have some outcome. One of them is that the bowel will be in abnormal position. For example, look at this one. In this one, we see that the large bowel is on the left and the small bowel is on the right. So that's an abnormal position. You can also follow the duodenum. Look at that duodenum. Now the duodenum, we know that the duodenum should cross like this, third part, and then fourth part somewhere, but see where the third part and the fourth part are, they're down here. That's an abnormal position. So we may have abnormal positioning. We may also have shortening of the base of the mesentery. Look at this normal, and this is the mesentery. See the base of the mesentery is quite wide here. But on this one, the base of the mesentery is narrow. And because of that short base of mesentery, it means that this intestine can easily twist on itself. And the twisted intestine at the mesentery is what we call volvulus. So because of that short neck of the mesentery, it is more prone to rotation, which we call volvulus. And this one can cause obstruction. The other manifestation of malrotation is that you may have abnormal bands crossing within the mesentery. And this is an example of such a band. These bands are called the Latz bands, like that band there crossing. So basically, these are the results of improper rotational process. Now, we make a diagnosis of malrotation of the midgut based on some critical anatomical landmarks, which may be then not properly placed. One of them is the location of the duodenojejunal junction. Remember that the duodenum comes like this, like in that image up to there, and that position, the duodenojejunal junction, is usually marked by the presence of a suspensory ligament, which we call the ligament of Treys. Now, in a normal position, that ligament or that junction will be at that point. But in malrotation, we see that that particular point is displaced, both inferiorly and medially, as we can see in this one. So it will be somewhere down there. It is displaced inferiorly and medially. Now, because of that, the other implication is this. The third and the fourth parts of the duodenum, they're usually fixed. The third part is this part here, horizontal part, and the fourth part is that part, the ascending part. These parts are usually fixed, and they're retroperitoneal. They cross the spine and go that way. But in this particular situation, the D3 and the D4 part are interperitoneal, and they hang freely down, as you can see in this particular one. So they're not in their normal position, and they're also interperitoneal. Very important to note about malrotation. And so radiologically, we make a diagnosis of malrotation after some contrast has been put in the GIT, and we follow through and we see that in this particular image, for example, look at where the small intestine is. The small bowel is on the right side and the large bowel is on the left side, telling us that that's malrotation. Now, what will make this become symptomatic? Maybe if there's malrotation and there may be no symptoms, but we may get symptoms if the following occur. One, because of that short mesenteric base, you may have volvulus, as I mentioned to you, and that will cause obstruction. that will be symptomatic. Or 2, if the abnormal peritoneal band also causes some obstruction, that will also be symptomatic. So sometimes you may not have the volvulus itself, but the lat band is causing obstruction. That will still be symptomatic. Otherwise, if in the absence of those ones, you may not have symptomatology. So this image shows you the short mesenteric base. It also shows you the abnormal position of the organs, large bowel to the left, small bowel to the right. Look at the position of the cecum, much up instead of down there. It shows you the lat band, the presence of the lat band. So this band can cause obstruction, and that can give you symptoms. But also this narrow neck of the base of the mesentery may rotate on itself, as that arrow shows. And when that happens, it can twist, therefore, and that is what we call volvulus. That can also cause obstruction. That is malrotation of the intestines, largely affecting the midgut, and so that's why we prefer also calling it the midgut malrotation. Radiologically, we make a diagnosis of volvulus by seeing that corkscrew appearance of the small bowel, and specifically at the level of the duodenum. So when you see that corkscrew appearance, we know that this one has now gotten volvulus. The next one is what we call Hirschsprung's disease. Hirschsprung's disease is basically characterized by the absence of myenteric and submucosal ganglionic cells along a variable length of the distal GIT. Now, let me put that in a different way. It is characterized by absence of the enteric nervous system. And this one largely affects the lower GIT. It could be a variable segment, which means it could just be a small part of the rectum or the whole of the rectum, or the whole of the rectum plus a small part of the sigmoid colon. Could be rectum and the whole of sigmoid colon. And the concept is that it could be variable segment. But remember, it's affecting the distal GIT. What is it? There are no neurons within the walls of those particular segments. Why are there no neurons? Probably because, remember, we said that neurocrest cells are supposed to migrate in a craniocaudal sequence to the GIT. So we think that this is due to failure of complete neurocrest migration. So if there is incomplete migration of neurocrest cells, then those neurocrest cells could not then become the enteric nervous system in those particular segments which are affected. Maybe that is a concept. The other concept to think about is maybe there was migration, but something could have destroyed the cells, either way. So fundamentally, what we are saying is that we don't have the neurons in the distal GIT. So if that is the situation, remember, these neurons usually coordinate and facilitate relaxation of the bowel. So contraction and relaxation, fine. Now, if they're not there, what happens? If these neurons are not there, the segment of the bowel that is lacking them cannot coordinate relaxation when we have things moving down. So the result is that that segment that cannot relax will be spastic and will cause obstruction to movement of material down the GIT. So because of that, it means that when this child eats, the particles will just come and accumulate on the last proximal normal segment. The abnormal segment, the part that doesn't have the neurons, will not relax. And so material cannot go down to that region. There'll be obstruction, basically. Because of that, therefore, we see a transition zone, a very sharp one. Material will be accumulating on the last normal part, and so that part become dilated. And that is why we sometimes call it megacolon. That part become dilated. Then the abnormal part is very narrow. So there's a sharp transition there. Radiologically, we can capture that again using some studies where in this particular image, you can see perhaps this is the colon. We see that dilatation there, very prominent. Then we see a sharp transition so that the distal part of the JT there, this narrowing. So there's a transition there. Even this one, there's a transition there. Perhaps that's at the level of the descending colon. Is that sharp transition? Now, because children are born with this, we call it congenital. Because there's a segment that does not have these neurons, we call it a ganglionic. And because it manifests with distension of the colon, we call it megacolon. And so it's usually called congenital aganglionic megacolon. Clinically, these babies will present with delay in passing the first stool, what we call meconium. They'll have a delay in passing meconium. And then progressively, their abdomen will be distending because of the megacolon. Another anomaly of the intestine, now we're going much down. This is at the level of the anus. In this particular image, you see a child without anal opening. And in this particular image, we appreciate that there is no anal opening. So we can just call it anal atresia or imperforate anus. Remember, from embryological point of view, that the anus has dual embryonic origin, the proximal part coming from the septation of the cloaca, the distal part coming from the proctodium. So this part here from proctodium, this other part from the septation of the cloaca. The two should make a communication after the anal membrane has perforated. So failure of degeneration of the anal membrane will give you this imperforate anus, or what you're calling anal atresia. You may have anal atresia like this without any fistula, to mean that the stool is not redirected to the urogenital system. But you may also have anal atresia with some fistulae. And the images we are having right now show us situations of anal atresia with some fistulae. Now, look at the first one. In the first one, stool is redirected to the urethra, and this is a situation of a male child. We call this one anal atresia with urorectal fistula. In the second one, a female child, stool is redirected to the vagina, and so we call this one anal atresia with rectovaginal fistula. Good, so those are the anomalies of the intestines. There's still some anomalies of the intestines that I've not talked about because they fall under anomalies that also affect the anterior abdominal wall. And that's why I thought to be nice then to have just a line on malformations that involve the anterior abdominal wall, so that we'll mention all of them, the anomalies that affect the anterior abdominal wall. And in the process, we'll also mention those anomalies that still involve the intestines, but also involve the anterior abdominal wall. Now, let's talk about those anomalies that involve the anterior abdominal wall. So these ones may or may not have involvement of the intestines, but they still affect the anterior abdominal wall. Let's start with this one. We call this one omphalocele. Omphalocele results from failure of the umbilicus to close completely. Now remember that there was a time that there was a herniation through the umbilicus. The intestines herniated, and then they went back. After they went back, we expect the umbilicus to close. If the umbilicus does not close completely, there'll be trouble. The trouble here is that now abdominal contents can easily again herniate through that same umbilicus outwards. And that is what we see in this particular image. So what herniates here would be bowel plus other organs. You can still have the liver there. Things herniate through that particular defect. Now, importantly, the organs that herniate are usually covered by a membrane. And that's very important to distinguish it with another one that we're going to see again shortly, that in this particular malformation, the herniated organs are covered by a membrane. That membrane is usually consisting of the amniotic membrane, Wharton's jelly, and peritoneum. At least there's a membrane that covers them. We can make a diagnosis of omphalocele even before birth, after we have expected the bowel to have returned into the abdomen. Remember that physiological herniation occurs in the 6th week and the return by 10th week. So if by that time there is still organs outside and comfortably after 13 weeks, there are still some things outside, we can actually make a diagnosis of omphalocele at that particular time, because we expect that physiological herniation has already returned by that time. So if things are still outside the fetus by that time, we can make a diagnosis of it. And in this particular image, that's what's being captured there. We can see the herniated bowel, or at least abdominal organs through the umbilicus. So we can comfortably say that that is omphalocele if I gave you the timing for this particular scan, that let's say it was done at 15 weeks or 16 weeks, then we know that definitely that one is omphalocele. Omphalocele may have multiple associations, so it may not just be existing on its own. So when you see one, we usually look for other anomalies. These are still images of omphalocele. You can see that there's content covered by membranes. Even this one, there's a content outside covered by membranes. So that's the hallmark. Usually an umbilical defect. Things are popping out through there, but there's a membrane covering. So you understand it's still an anomaly of the anterior abdominal wall, but it's also affecting the intestines. Let's compare omphalocele with this other one, which you can easily confuse. Actually, this is gastroschisis. In gastroschisis, we have, again, an anterior abdominal wall defect, usually lateral to the umbilicus. Now, it's not umbilical, but lateral to the umbilicus. It's paramedian. It's not median, but paramedian. And most of the time, it will be to the right of the umbilicus, which means that in this particular situation, the umbilical ring has closed normally. So it's not omphalocele because umbilical ring has closed normally, but there's a defect to the right of the normal umbilical ring. The cause of this one is controversial. There's some theories that explain why we can have a defect lateral to the umbilical ring. One theory suggests that you may have had an early involution of the right umbilical vein. Remember that initially we have 2 umbilical arteries and 2 umbilical veins. The 2 umbilical arteries persist until birth, and they're found within the umbilical cord. For the 2 umbilical vein, the right one usually disappears, involutes. The left one persists. So that in the umbilical cord of the mature fetus, we have only 3 vessels, 2 umbilical arteries and 1 large umbilical vein. The large umbilical vein that is there is usually the left umbilical vein. It's the one that passes throughout. The right umbilical vein usually involutes during pregnancy. If you have early involution of the right umbilical vein, it may cause weakening of the anterior abdominal wall in that region. And that is why the defect is usually almost always on the right. Well, there's another theory that suggests that you may have vasoconstrictive events that cause ischemic injury and weakening of the wall. So that's another theory, largely because of vasoconstriction and ischemia. So there's weakness of the wall. Whatever it is, these are just theories. The fundamental truth is that there's a weak point, there's a defect in the paramedian anterior abdominal wall, and through that defect, organs now come out. Now, the organs that come out through that defect are therefore not protected by a membrane. Remember that one, very unique to distinguish it from omphalocele. Here, the membranes are lacking. Whatever is coming out are not protected by the membranes. And so because of that, the bowel that is coming out or the organs that come out are more subjected to pathological changes and complications compared to omphalocele. So in terms of just what changes will be found in the bowel wall, these ones, the bowel walls will be undergoing thickening and hardening because of those pathological changes, because of exposure, direct exposure to the amniotic fluid, compared to omphalocele where they're protected. So these are images of children with gastroschisis. We can see bowel out, no membranes, even this one, bowel out, no membranes, bowel out, no membranes, even this one. That's the point. Bowel out, no membranes. Remember, usually paramedian. Another anomaly of the anterior abdominal wall, and is very common, is congenital umbilical hernia. We can see that protrusion at the umbilicus. Many people have this one really. Congenital umbilical hernia basically is caused by incomplete closure of the anterior abdominal wall after the gut return to the abdominal cavity. Don't confuse it with omphalocele. In omphalocele, we didn't have skin covering. But in congenital umbilical hernia, there is skin covering. And that is important to note. So yes, the anterior abdominal wall has not closed well. And so bowel, or rather abdominal organ still herniating, but the skin covering on top. The sac, the hernia sac within here usually contains just fat. It can also contain mesentery, or it may contain some part of the intestines, depending on how big the hernia is. Importantly, the content of the sac are covered by skin, and that really distinguishes it from omphalocele. So that's what you see there. So we have the hernia sac there, perhaps formed by peritoneum, and we have the skin there and the anterior abdominal wall. So it's protected. These are images again of children or even adults. Okay, that was a child. These other two are basically adults with the umbilical hernia. That's the hernia in this particular child. In this particular still axial image of the abdomen, at the level of the umbilicus, we see that protrusion there. You know, this is skin, this is fat tissue, this is anterior abdominal wall muscles. So we'd have expected here to be just straight there, but you see content there. So this is herniation. And the last image is a video playing, and I want you to see where the defect is. So this is the anterior abdominal wall. Let's just follow that one. We can see that's the anterior abdominal wall. We are scanning through. So the recti muscles, now that's the hernia. You can see the hernia there. Then again, anterior abdominal wall. These are rectus abdominis muscles there. Let's follow back again. The recti muscles, and then that is the hernia sac at the level of the umbilicus. And this one may be undergoing incarceration. You can see there's a lot of gas and fluid within the bowels. There's some pathologic changes already occurring. Another anomaly that affects the anterior abdominal wall is the pentalogy of Cantrell. Pentalogy of Cantrell is a syndrome consisting of a spectrum of 5 ventral midline anomalies, and that's what it's called, pentalogy 5. Fundamentally, the hallmark of pentalogy of Cantrell are 2 important observations: that the individuals affected have an omphalocele and ectopia cordis as well. That becomes the hallmark of the disorder. And now I'm saying this because in as much as it's a spectrum of 5, you may not necessarily have all the 5 in a particular child, but you'll have these 2 most of the time. And so this becomes the hallmark of it. But the full pentad will have 5 of the following 5. 1, that is a midline supraumbilical abdominal wall defect. And because that midline supraumbilical, above the umbilicus, defect, it will be causing an omphalocele. So these babies have omphalocele. There's omphalocele coming out, which means that a bowel coming out with a membrane covering them. There's an omphalocele. And because that omphalocele is so giant, the right and the left rectus abdominis muscles are separated significantly. This diastasis of the rectus abdominis muscle. So that's one component. Second component is that there's a defect in the lower part of the sternum. And because of that defect in the lower part of the sternum, it allows the heart to protrude through that defect to the outside the thoracic cavity. And that's basically what we're calling ectopia cordis. The heart is out. The heart is ectopic. There's also deficiency or a defect in the anterior diaphragm. And because of that defect in the anterior diaphragm, you'll have herniation of abdominal organs through that defect. So there is anterior diaphragmatic hernia. Abdominal organs herniate through the anterior diaphragmatic defect. It could be part of the omphalocele as well. Yes, there is also a defect in the diaphragmatic pericardium. Remember that pericardium is the covering the heart. So usually the pericardium covers the heart completely. The lower part of the pericardium related to the diaphragm is not there. So because of a defect in the pericardium that usually lies on the diaphragm, the heart will have to go through that defect. And so that is still explaining the ectopia cordis. So that the heart descends from the thoracic side to the abdominal side, still explaining ectopia cordis. And lastly, we have congenital intercardiac malformations. It could be ventricular septal defect, a communication between the right and the left ventricle, an atrial septal defect, communication between the right and the left atrium, tetralogy of Fallot, where we have 4 things occurring. We have pulmonary stenosis, overriding aorta. We have right ventricular hypertrophy. And lastly, we have the ventricular septal defect. That is part of what we call tetralogy of Fallot. Again, you may also have ventricular diverticular and outpouching from the ventricle or just aneurysm of the ventricles. That is what constitutes pentalogy of Cantrell. Remember, the full pentad is rare, but fundamentally, the moment you see omphalocele and ectopia cordis coexisting, we call that pentalogy of Cantrell. So these anomalies show us the pentology of Cantrell, we can see that that's the heart. So we have ectopia cordis, and we can see bowel there, omphalocele there, written O there. Well, we can also see herniation there, large bowel, small bowel, herniating, that spleen, things have herniated there. So there's herniation. Because there's a herniation, there's a defect through the diaphragm and the anterior abdominal wall. But there's still omphalocele because you can see membranes there. In this particular image, again, we can appreciate the ectopia cordis there. We can also appreciate the massive herniation there. There are also other malformations that this baby is actually having, as you can see. Even the first one, you can see in the face, there are other malformations. So there could be other associations. Let's talk about another one, prune belly syndrome. Prune belly syndrome is a complex disorder that is characterized by the following features. One, we have gross pelvic-calyceal and ureteric dilatation with renal dysplasia. What does that mean? First, the kidneys are underdeveloped or abnormally developed. That's what we're calling renal dysplasia, abnormally developed. In addition to that, the renal pelvis and the renal calyces are dilated. Also, the ureter is dilated. So there is some tortuous outline of the collecting system of the kidney, and that particular kidney is not well developed. Two, we have anterior abdominal wall underdevelopment, resulting in what we are calling the prune belly appearance. Now, this is usually about the musculature. The musculature of the anterior abdominal wall are underdeveloped. They are hypoplastic or basically not there at all. So that what you have is just skin, no muscles. And that's what gives the appearance that they're calling prune belly. I'll show you some images. The other component of the syndrome is that there is a bilateral undescended testes in the male child. So for the male child, the testes will not be in the scrotum as we expect. They'll be somewhere in the abdomen or in the inguinal canal. And that's what we call cryptorchidism. So bilateral cryptorchidism. Sometimes they may also have a very hypotonic urinary bladder, but that may not be the diagnostic criteria for many times. But yes, some children have hypotonic urinary bladder. Urinary bladder is not very contractile. Usually when there's prune belly anomaly, there are multiple other associations. So a baby with prune belly syndrome will also have or may also have some malformations of the respiratory system, gastrointestinal system, musculoskeletal system, and even cardiovascular system. But the entry to the diagnosis of prune belly syndrome relies on the first three. These are images of children with prune belly syndrome. So I intentionally just gave you the one that are involved in the anterior abdominal wall so that you can see why we call it the prune belly, and ideally because we're also just looking at anterior abdominal wall defects. So you've realized that this is less to do with the intestines, but it's still an important anomaly to talk about because it affects the anterior abdominal wall. You can see how hypoplastic, if you can see that, of the anterior abdominal wall. The point here is that we don't have the musculature. Either they are absent or they are hypoplastic. The other anomaly to talk about is body stalk anomaly. We may also call this one limb body wall complex. Body stalk anomaly is a varied group of congenital limb and body wall defects. So they affect the limbs, but they also affect the body wall, and the body wall we're talking about here is chest and abdomen primarily. The following constitute the complex. So they may have abdominal cysts, which means that there's a split in the abdomen, and that will cause some large things to come out. There is a split in the abdomen, usually large and left-sided, and almost always present. There's also a thoracic wall defect, or that's what we call thoracostosis, which means that there's a split again in the thorax, and that will expose the heart. Then there's some malformations in the lower limbs, either clubfoot, brachydactyly means short digits, polydactyly means multiple digits, syndactyly means few digits, oligodactyly fewer digits, and amelia, absence of a limb. Then they have severe scoliosis. Scoliosis is lateral bending of the spine. They may have exencephaly, which is exposure of the brain, basically. So these ones really look ugly. Body stalk anomaly really look ugly, but you can appreciate the severe scoliosis in all the 4 cases presented here. These 2 were actually twins, but they both had the anomaly. You can also see the thorax and abdomen are all affected, with abdomen and thoracic organs just exposed. So affecting the thorax as well as abdomen. And then if you look carefully, the limbs also have some anomalies. This limb has an anomaly, that limb has an anomaly. The right limb, there is not there. We're not able to see that one nicely. Okay, the other anomaly talk about is bladder extrophy epispadia complex. It's a spectrum as well. So this spectrum, the mildest form of it is the epispadia, and the severe form of it is what we call cloacal extrophy. Epispadia simply means that the urethra is opening on the upper part of the penis. So the penile urethra opens on the upper part. That is epispadia. So that the urethra is not opening at the tip of the penis as we expect, but on the upper part. Bladder extrophy is where we have an anterior abdominal wall defect, and then the anterior wall of the bladder is also not there. So what we have is the inside of the bladder with its posterior wall being exposed. We are seeing the mucosa of the bladder being exposed in the anterior abdominal wall. And I'm going to show you some images. That is bladder extrophy. Then cloacal extrophy is where we are exposing similar concept as bladder extrophy, but in this case, we are exposing both urinary bladder as well as the anorectal lumen that is being exposed at the level of the cloaca. Basically, remember, cloaca is amalgamation of the urogenital system and the digestive system. Most extreme of it is what we call OAS complex. OAS complex stands for omphalocele, cloacal extrophy, imperforate anus, and spinal defects. So the O there for omphalocele, E there for extrophy of the cloaca, I for imperforate anus, and S for spinal defects. Now, these images show you images of bladder extrophy. All the 3 show you bladder extrophy, well, with epispadia as well. As we can see in those children, there is epispadia. They're all male. We can see that the scrotal sacs are full, so they contain testes. But the penis is rudimentary, and there's a split, basically. That's severe epispadia. These other images show us cloacal extrophy. So both contents of urogenital system and anorectum are exposed. This is cloacal extrophy. And this one shows us the OAS complex, where now we have omphalocele present, as you can see in the images. We also have extrophy of the cloaca, or at least of the bladder there. We are seeing that one. Of course, we've not been able to see the spinal defects and imperforate anus, but Yeah, in this particular image, you can capture that one. So this is OS complex, the spectrum. Very good. So those are the anomalies of the anterior abdominal wall, and that summarizes the anomalies that I want to talk about. Thank you very much. So we have looked at development and congenital anomalies of the hologenity in two parts. First part, we just looked at basic concept of formation of primordial gut tube and derivatives of the primordial gut tube and embryonic origins of the JT. In the second part, this one has been long, but we've looked at development of the esophagus, stomach, and the intestines. And we looked at the anomalies as well. But in addition to that, we've also looked at anomalies that affect the anterior abdominal wall. So the last lecture on GIT series will be development and congenital anomalies of the hepatobiliary system. We'll stop there for now. Thank you very much.